All right, welcome everyone. We are here to discuss um, uh, an entity that is described in our book. I'm Sanjay Mukhopadhyay, and this is my colleague, Dr. Matt Cecchini. And we together wrote a book that we are hoping is going to be useful for trainees as well as practicing pathologists. And we hope that we are approaching this in a new fashion in terms of describing things in terms of where you find them, whether you find them in a small biopsy or at frozen section or on dissections. So here's a case. Welcome, Matt, by the way. Welcome.
Hi, Sanjay.
So we're going to just talk about this case, Matt. Let's just walk people
Yeah,
through how we have walked people through this entity in our book. So we've got a
it's a
resection
resection case. Yeah,
specimen. So this would be in our resection specimen chapter.
yeah,
You can see there's a lot of lung around it. There's some blood there.
yeah,
And then there's obviously a nodule. So Matt, I'll leave it to you to describe a little bit. I'll take it in and out and take it over. Go
yeah.
ahead.
So it looks like we have first at low power here. Actually, this kind of caught my eye. These kind of like hemorrhagic spaces there that almost look like blood lakes. I think that you could describe them as. And then this lesion seems relatively well demarcated against the adjacent lung there. And then the lesion itself seems a little bit heterogeneous, where we have these areas of this blood-filled blood lakes. At this low power, I'm also seeing that there's some more of this hyalinized type stroma here that looks very pink. And then we have areas that are a bit more cellular, and they seem to have a range of patterns at this low power. And then in some other areas, it looks a little bit more gray. I wonder if there's some accumulation of some foamy macrophages in there as well.
Okay, so let me take you to
Yeah.
higher mag in each of these areas. So here's the first area you described.
Yeah, so this is this area we have this accumulation of blood. It looks like there's some intervening kind of fine, delicate spaces in there that are lined by these cells that are a little bit cuboidal. It's a little bit hard to see with some of that hemorrhage in there, but I think I'll be able to see the cells a little bit better in some of the other areas.
Yeah, that's
Uh,
great. And then let's get you to these sclerotic areas that you noticed at.
yeah, so this very pink sclerotic areas that have these intervening areas of these more epithelial looking cells in between them.
Yeah. And then let's try to take you to one of those cellular areas that
Hmm.
you noticed. So how about something like this, man?
Yeah, so it is quite cellular once again. The one thing I am noticing is that while it's cellular, the cells themselves don't look that atypical. They're a bit more bland than I would think in a typical adenocarcinoma type of picture. I assume this was taken out for a suspected mass or lesion.
Yes.
Was it a traditional patient, or was there anything different about this
Yeah,
patient?
I think it was a slightly younger woman. I don't know
Okay,
the exact age, but yes, a woman and a
right.
slightly younger. So it's not quite the traditional for
Yeah,
for a non-small cell carcinoma, which would be generally an older patient or at least a 50s, 60s
yeah.
tradition. Yeah.
Definitely. And I think that there's some cells that look a little bit more here like type 2 reactive pneumocytes. And then inside here, there's some other kind of a little bit more distinct cell population that seems to be more growing in kind of solid areas in between these areas that are lined by these type 2 looking appearing cells.
Yeah.
So, I think these lung masses, you always need to think about a lung cancer, but I think, given that the history is a little bit off for this one too, and we're seeing some other features that are not really completely typical for a traditional lung adenocarcinoma, I think we should think of some other diagnostic possibilities.
Yeah.
So,
So,
go ahead.
Matt, we talk about this two cell population,
Yeah,
this tumor in our book. Can you explain to the audience what the two cell population is?
yeah. So we have one cell population here, which I'm just kind of highlighting there. So these would be these type 2 appearing cuboidal cells that kind of have a bit of a hobnail appearance to them. And so these will stain like an epithelial cell. And then the other population is these round cell population here, which are also somewhat bland, but they kind of grow in more this sheet-like pattern here. And they have these round oval nuclei. And these ones should have a very distinct staining pattern where they'll be TTF1 positive, but keratin negative. And that can be really helpful in making this diagnosing of a sclerosing pneumocytoma.
Yeah. So all you need really is a TTF1 and a keratin, right, man?
Yeah.
What about if you had other differentials, like
Mm.
if somebody was wondering, if they looked only at this land population and wondering, well, could this be a carcinoid tumor? What could you do to rule that out?
Uh, Definitely. Well, you could do some neuroendocrine markers
Yeah.
to rule it out. To me, the chromatin's not perfect for it.
Right.
I guess salt and pepper is a bit in the eye of the beholder, but the other thing is, to me, it doesn't have that nested architecture. So to me, it doesn't have architecture or nuclear features of neuroendocrine differentiation. And I'm always hesitant to put neuroendocrine stains on something that doesn't have clear neuroendocrine differentiation, because then sometimes you get some positive staining and you don't know what to do with it. I don't know how you feel about that, Sanjay.
Yes. No, I think that's correct. I also hesitate to put neuroendocrine stains on things that don't look neuroendocrine. And I think we also mentioned this point in our book. We make a
Yeah,
point to emphasize this.
definitely. Because the sclerosing pneumocytoma should be negative for neuroendocrine markers, right?
Correct. They should be negative for neuroendocrine markers. So I think we have covered most of the histologic clues
Yeah,
and really the immunohistochemical profile of this tumor. Also worth mentioning that at the periphery, this can look very papillary
yeah,
and
definitely.
complex. And so definitely there's a possibility to mistake this for an adenocarcinoma. But you were also right about the foamy macrophages, Matt, and that also serves as a clue. So if you put
Yeah.
it all together, the foamy macrophages, the sclerosis, the two cell population, and importantly, that the resection is from a woman, I think you have a pretty good, strong diagnosis here
Yeah. So,
of sclerosing pneumocytoma.
Jay, could you just comment on some tips or tricks on what to do with this at frozen section? Because I can imagine that this would be really hard on frozen section to not call adenocarcinoma, especially given those areas with papillary growth and things.
Yeah, I think it can be tough and you can be misled. I think you should be on your guard anytime you're looking at a frozen section from a woman, especially if it's from a relatively young woman.
Okay.
And then again, look for the same things, the same features, the two cell population, sclerosis, foamy macrophages. But one thing you can do is talk to your surgeon or look up the CT. I know, Matt, you do this in
Yeah, I
preparation
do.
for
Yeah.
your frozen. And there it really helps because in most cases, this will show a sort of well circumscribed small nodule,
Okay.
and that should also it should put you on your guard, because if you're considering in the differential a low grade adenocarcinoma because of the low grade cytology of the cells, or some sort of a lipidic type adenocarcinoma, those should usually be ground glass or at least partially ground glass lesions. So if you see
Mm.
a solid small lesion that corresponds to this histology in a woman, I think those are clues to back off from adenocarcinoma and at least suggest a sclerosing pneumocytoma. You might not be able to on a frozen do it with 100% certainty of, you don't have access to immunostains,
Definitely.
but maybe you could suggest it or say defer to permanence and not call it malignant. That's the main important
Yeah.
thing.
I'm not sure if you're aware, Sanjay, what's the typical management of these cases? Like, if you were to make this diagnosis on a smaller biopsy, do they typically conservatively remove them, or do they follow these? Or
Yeah, I think you could follow it. I think there's an argument for following it, but I think in my experience, they will resect them. They'll resect it with a wedge resection.
okay.
um i I don't know why they do that. Is it because they just want to be sure that it is benign,
Yeah.
whereas a small biopsy diagnosis can be difficult. But yes, I think the main thing is to avoid a lobectomy, which
Okay.
would be unnecessarily aggressive surgery for this. But I think a wedge resection is reasonable,
Okay.
just to remove the lesion, but these are completely benign, so
Yeah.
theoretically you could avoid a resection completely.
That's a good point. So I guess it's important role for the pathologist here in frozen section is that we could prevent a patient from needing a lobectomy by making this diagnosis of a sclerosing pneumocytoma.
Absolutely. All right. Thank you very
Wonderful.
much, Matt. This was
Thank
a
you.
really interesting discussion, and I hope that our the readers of our book and viewers of the Innovative Pathology YouTube channel find this discussion helpful too.
Wonderful. Thanks so much. Have a great day, everyone.